Dr. Susan LeGrand, currently working in Charlotte in the Department of Supportive Oncology, spent 20 years at the Cleveland Clinic doing palliative medicine, prompting my move to Charlotte to do it again. Disclosures, I have nothing to disclose. So I get this with this lecture to understand the role of palliative sedation, and particularly at end of life, know the ethical concerns regarding sedation, better understand pain symptoms at end of life, and know the symptoms most associated with requests for medical aid in dying, subsequently to be called MAID. So the symptom burden in cancer at end of life, this was a study of 1,159 patients. Total symptom score was moderate to severe for the group. So physical symptoms, 55% had significant physical symptoms. Now, the predominant ones at end of life are not necessarily pain, as noted here. Tired, drowsy, and anorexia are the most common. 49% of patients would have pain. Psychological symptoms are significant also, 35%. And anxiety and depression are the most common symptoms in this setting at end of life. The factors that had higher intensity scores tend to be women. Lung cancer patients seem to have more symptoms, those who were getting closer to approaching death, and there was minimal improvement over time. So the symptoms did not seem to get better despite interventions to try to improve them. They did not improve very much, which is distressing. So we're going to talk about palliative sedation. It was initially called terminal sedation, and then back in the 1990s, there was discussion to change the term to be palliative sedation, and that is what it's called to this day. So it is a deliberate reduction in consciousness. The goal is to have a level that's adequate to relieve refractory and intolerable suffering of this person. It's important to understand that hastened death is not the intent. So double effect comes into play here, where we're doing something that's appropriate, but our intent is not to hasten death. Ethically, it remains controversial still, and the incidence varies dramatically from 0% to 55% of patients being sedated, which argues that there may be differences in terms of symptom management in groups that require so high a percentage of sedation. So the patient's selection for a terminal illness, probability of death in less than 2 weeks. And this is problematic for the physicians who are making recommendations for sedation because prognostication is quite difficult. So you never know if you're picking the right person, and that leads to a lot of stress with physicians and other healthcare providers. The conventional therapies are not managing it without a change in consciousness. So you're not able to manage what you need to without changing this person's level of consciousness. You got to have a goals of care conversation, preferably when the patient can still be included in the conversation and they accept the sedation adequately. And you've got to have refractory symptoms. And that is also controversial, what symptoms are included. I'd like to comment on this reference. This is an educational reference that comes out of the NCBI bookshelf, which is a 2024 article that goes through all of these things quite clearly. And so I would recommend that particular article, which you can find in a regular list of search engines. Characteristics of those patients who got sedation, they were younger. They were male predominantly, cancer predominantly, and the predominant symptoms were dyspnea and delirium. Pain is on the list, and most of these are taking place in hospital settings, sometimes in an inpatient hospice setting, typically not at home. So these patients are not living at home. They're in a facility of one kind or another, typically in hospital settings, coming in because of uncontrolled symptoms. So what's a refractory symptom? A patient who has intractable symptom, they can't tolerate another intervention. So, for example, which we'll talk about in a minute, they've got a disease that's got a problem that might be able to get radiated, but they're just not in the position that they can do that. Would risk other toxicities. Now, I don't read too much about QTC prolongation these days. It's like almost every medicine causes it. You never prescribe anything. So in an end-of-life situation, that would not be very high on my personal list, but it is one of the things that's defined in refractory symptoms. Other alternatives are not readily available. They would take too long to work, or they will have a low probability of being effective. Now, it's important when possible to have a consult to palliative care or pain management to make sure that we've done everything we can before we go into sedation. And I think that's a critical thing. The problem is sometimes there's not a person available to do that kind of consultation. More apt to have a pain management sometimes than a palliative care physician. But having a consult with someone who may be better able to manage these symptoms before they're declared refractory would be the preference. So there are different types of sedation. Ordinary sedation, this is a medicine you're giving them, a pain medication, it's making them a little bit sleepy. That's not the intent. So you're going to adjust the dose, so you're going to change the medication to find the right one, because the change in consciousness is not the intent. Then you have proportionate palliative sedation. So you start a medication and you gradually increase it until you find the level that's effective and that gives a symptom relief that's acceptable to that patient. And you're doing other things at the same time. You are not trying deliberately to change the consciousness of this patient, although you may, to some degree, cause some change that may not be permanent or may not be all day. They may wake up in the daytime and have conversations and then slip that off, as opposed to palliative sedation, which is the goal is unconsciousness. That is the intent of what you're doing, is to make this person unconscious and leave them there until death occurs. Then there's something called respite sedation or brief sedation. And this is planned and temporary. So anywhere from 1 to 48 hours. And this is a situation where the patient is so stressed from whatever symptoms going on that they just need a break. Maybe they're not going to need continued sedation. They just need to get away from the stress that they're in right this minute. Most patients then were able to stay off sedation once they came out of it, once it was dropped, that they were able to stay awake. There were several in a study that I could not find the reference for, but I swear it happened, that just went back to sedation to do a sedation to unconsciousness. But it is not intended to do that except for a very short period of time. Particularly, this can be useful in emotional issues related to they're in pain, but now they're so stressed that they're just not coping. And so giving them a temporary break can be helpful. So what about the ethics of this? This is a constant conversation within the field of palliative medicine. So is this euthanasia or is it medical aid in dying? Does it shorten life? Major controversy on do you do it for emotional suffering? Some places do, some places do not. For me, goals of care here, proportional sedation, we're only trying to do symptom relief. MAID is life termination at the patient's choice. So they make the choice of when this occurs. Whereas euthanasia is immediate, you give a drug with the intent of taking that person's life. Now, when you look at the studies that have been done, they have not found any difference in survival with palliative sedation, even with going to deep unconsciousness. The studies have not been able to demonstrate a change in survival because these, again, are patients who are close to dying anyway. And so there's not been a huge change in life expectancy, which averages in the week to 2 week time as expected when you chose this patient to begin with. So it's hard to differentiate pain symptoms these days because a lot of what's happened is we just talk about the group of symptoms, dyspnea, agitation, delirium, and pain, but not going and saying, okay, this is how much dyspnea, this is how much agitation. Those studies are older, So that's what's going to be referenced here. And again, they typically differentiate psychological distress. And as I mentioned, there are much more ethical concerns about this. MAID is allowed, and euthanasia is actually allowed in Canada these days. And emotional support, emotional suffering has been used, particularly in the Netherlands. I personally have problems with that. It would not be something that I would be able to do to a patient without having good treatment for what is going on emotionally. So the first kind of reports back in the 1990s of other than just a single case report was a study of 120 patients that required sedation. Dyspnea was the most common symptom that required it, and only 25% of this patient population had pain. Dyspnea is one of the most common reasons why sedation gets started in the palliative care population. Pain is certainly on the list. So they measured the symptoms here at referral. So this is pain incidence at referral to a palliative medicine specialty. 41% had it after referral, improved after 1 week, although this is not confirmed with some other studies. And weakness and dyspnea then became the primary symptoms prior to death. So pain got better with this particular study, and then weakness and dyspnea took over and still required sedation. Dyspnea in particular, weakness would not be a reason for sedation. Dyspnea can be quite hard to control by any other means. So these are, again, relatively old data. Lynn found 40% of patients were dying in pain. The Institute of Medicine found 40 to 80% reported inadequate control. So we were not doing a very good job back here. And admittedly, that's a while ago, and hopefully we're doing better. Then the data is iffy. So characteristics of the symptoms. Pain was the most distressing symptoms back at this old study of 82% on admission to hospice and palliative care. The distress from other symptoms related to greater uncontrolled pain. So if the pain was uncontrolled, then they were more short of breath, they were more mostly suffering, but the pain was kind of the lead symptom in this group of patients. They didn't get any worse. They didn't necessarily get worse as they approached death, but they also didn't find any improvement. So the goals of management of this patient population was not attained. So this was a distressing patient population with a lot of pain, other distress because the pain wasn't controlled, and they did not do much better in terms of trying to manage these symptoms. And what is the patient experience with care? So in this particular study in 2016, the majority, 83%, had pain. 25% were severe or used the word overwhelming. Family and healthcare professionals rated the symptoms differently than the patients, and they were still symptomatic after 3 days, which is the time at which they looked at this. So they weren't making any headway in the 3 days in trying to improve patient comfort without doing, this is patients who were not getting sedated on this particular study. But pain was the most distressing symptom in another older article. So it still was significantly a problem in older studies. Then there was a look at longitudinal symptoms. So in this study, 135 patients were studied. 77 had palliative care consultations, and 61% of those had pain with the first consultation. What they found was that earlier palliative care consultations, and this is a cancer group, they got earlier palliative radiation therapy consultations, which can be very helpful in this setting. Radiation oncologists who saw these patients then had the opportunity to get earlier palliative medicine consultations. So there's a lot of data these days that getting earlier palliative medicine is better. It's actually guidelined through the American Society of Clinical Oncology, ASCO, to get palliative medicine involved earlier in the cancer patient population. There's growing data on using palliative care in heart failure and COPD and other diseases that it would then deal more with dyspnea, although even heart failure and COPD patients can have pain that needs to be addressed in one manner or another. So does it work? Proportional and deep sedation. The medication most often used was midazolam. I personally never used that drug at the clinic. It was prior. We'd have to go through ACLS. We had to do all kinds of things in order to do it in a non-ICU situation. So we chose not to do that. It's called the drug of choice, but it's never been compared to other medications. So it's not clear that this really is the right drug. It's the drug that has gotten used most often. And it's the drug that is used in most articles that are published is using midazolam. And again, the primary symptoms that were used for this situation were delirium and dyspnea. Now, the alternatives. What we used at the Cleveland Clinic was carbamazine. And the person, Dr. Walsh, who started that program, which was the first palliative medicine program in the country, wrote an article after doing some research on a small number of patients with carbamazine. Now, if you look in the write-up for carbamazine, like on Up to Date, it says you can't give it IV. You can give it IV piggyback. You can't do an IV push. So we use piggybacks over 15 minutes, and then that was adequate. We had to adjust the dose. We would start with 25 and adjust the dose as necessary, but it was quite effective in keeping people sedated who needed to be. Barbiturates are another option. So if we did not get adequate benefit from carbamazine, we used phenobarbital, and that was also quite helpful. Dexmedetomidine has been used in the ICU, and there have been a couple of articles looking at that to see about that in the case of palliative sedation, and it has been helpful. Propofol has also been used for sedation specifically. There again, most often in an ICU setting. So in this study, they looked at it 4 hours after initiation. And the goal of proportional was symptom relief without agitation. The goal of deep sedation, as we mentioned, was the achievement of unconsciousness. So what were the results of this recent article? Proportional sedation, 77% achieved control. And again, this was not all pain. This is all refractory symptoms put together, some of which is pain. 45% of this group who got control ultimately required deep sedation. So they did proportional sedation to start with. It was okay for a period of time, and then it lost benefit, and then the patients had to be sedated to more consciousness level. With deep sedation, 88% of people were at goal, which was, of course, unconsciousness. Then 3 patients that didn't go to sleep, but they had symptom control. So the goal of sedation was more of a proportional sedation, and their goal was met. So proportional, many patients still require deep sedation. Deep sedation, an occasional person doesn't need it to the same degree. And then if they're comfortable, then you just don't pursue it further. So what does this do to doctors? So the emotional well-being of nurses and physicians was looked at in Japan and the Netherlands, at the physicians choosing sedation. And I think it's important to realize the Netherlands was the first country actually to allow what was then called physician-aided dying and euthanasia. So the fact that they're still doing sedation doesn't change the fact that they'll do the others if necessary, but they still do sedation in this time frame. So what they found was medium levels of emotional exhaustion, particularly because of the difficulty of identifying what was refractory, the difficulty of prognostication. So you're sitting here going, oh gosh, is this person going to die in 2 weeks? Is it longer? Am I going to cause this person to die quicker? Should I give them IV fluids? Should I give them nutrition, which of course you would not if you're doing deep sedation, because what would be the value of that? And then it's unclear what the patient's wishes and what the family wanted. So there's conflict between the patient and the family, or it's unclear what the patient's wishes are. So it's more difficult for the physician or the oncology and palliative care, and rather than general internal medicine or family practice, to get to know where to go with the choice of more sedation. What they found was the more exhausted these physicians were, the more likely they were to do sedation. And this may be an exhaustion, and I can't say this for sure, because they're not achieving what they want to with other symptom control. But is it really refractory? Is there something else that we could do? Could we do something that's more complicated? Is there anything we could do? But if you're just so tired about the whole thing, it's like, let's just sedate, which is not the way to go. It sort of starts to border on ethical issues if you're doing it because you're tired, as opposed emotionally tired, as opposed to your patient's symptoms. So what do we do? The first thing that I think is really important and maybe overlooked is you've got to rule out hyperalgesia. So if you're giving medications and the patient's getting worse instead of better, then maybe the problem here is not that the pain is uncontrolled, it's there's too much medicine on board. So they're dealing with hyperalgesia. Typically, hyperalgesia appears in one of two ways. It can be suddenly they hurt all over, as opposed to the spots they hurt before, or the character of the pain changes. So, for example, I was treating a patient on methadone infusion who got an intrathecal catheter to try to get off the methadone, and she wanted not to have to use it. And they came and increased her dose in the intrathecal catheter. Immediately, her pain became shooting, stabbing, neuropathic in nature, when it had not been that and had been purely nociceptive pain. I had to sedate her until they could come and lower the dose of the epidural of the intrathecal catheter. And at that point, her pain resolved back to where she had been. And we just had to continue her with the methadone infusion. And we also used the intrathecal catheter, made it permanent so that she had both things, because that was what was working best for her, was to have both. But she did not require sedation, and she developed hyperalgesia. The sedation was temporary, not even brief. It was just long enough to get the drug changed and the dose to get out of her system. Now, at the clinic, the Cleveland Clinic, when I was there, if you're admitted for pain control, you go on an continuous infusion of pain medication. And the rationale for that was, if you can control it with pills, why are you admitted to the hospital? You can adjust doses as an outpatient, but if they're coming in because their pain is not controlled with their current medications, then let's do something continuous. Maybe we can figure out the right dose. If they're capable of doing a PCA, then that's helpful as well. And then after a day or so, once you've got them in a comfortable place, you can convert them back to oral. But I think personally, again, that a PCA or continuous infusion would be the right way to go for someone who's been admitted for pain control. And this, again, would not be going for sedation. This is going for control. Unfortunately, it appears that some palliative medicine fellowship programs are not really teaching much about how to do a PCA infusion, which I think is terrible. It's something that should be mainstream for palliative care physicians to know how to do this, and to have a fellowship that doesn't really teach it is extremely problematic. Again, in a pain situation, one can consider adjuvants. So methadone has been looked at more in an oral situation where a single dose, and not even a terribly high dose, can be an adjuvant to improve pain control by using this at once a day, typically, just as an adjuvant to whatever other medications they're on. No intent to replace their current medications with methadone. This is purely adjuvant in nature. Ketamine is coming along. That Journal of Pain and Symptom Management, I left the date out. I apologize for that. It was also 2024. Ketamine is being looked at more and more for its possible involvement in pain control in this patient population. It's been done infusional, it's been done oral, it's been done other ways, other methods, buccal or other things to try and help it. There's an intranasal spray, but it's for depression. It's not been used in a situation for pain. But this is an option, again, to use as an adjuvant if you're not getting adequate pain control with your opioid. Other options that exist, steroids. So if you're dealing with bone pain, steroids can be helpful. If you're dealing with liver that's got stretch on the capsule because of the tumor masses within the liver, then steroids can sometimes be helpful for that. Intrathecal and epidural catheters. We don't typically do epidural catheters because they can move. So if we're going to do an intrathecal, typically that is also planned for outpatient management. So they're not going to stay in the hospital for the whole time. But it would be an option if you have someone in the hospital who could do it, and you've got someone who's got terrible pain who doesn't want to go to sleep, then you could put a temporary intrathecal catheter in with a plan to stay as long as necessary. If that patient stabilized, then you could certainly make it a more permanent situation. And then radiation therapy for cancer pain. We don't want to forget that there are things to do to treat the pain definitively. Now, radiation doesn't always take effect immediately. If you're dealing with bone, there is good data that you can use a single fraction rather than going 5 or 10 doses. So that might be possible for someone who is getting closer to end of life, perhaps not in the last 2 weeks, but moving in that direction. A single fraction for bone pain, it's a larger fraction, it's 800 rad, or centigrade rather, for a single fraction, which is much more than one would do if you were doing a 5-day or a 10-day course. But 1 day could be quite helpful for a person who's struggling with lung pain. Or liver pain, the liver can also be radiated 2 to 3 times to, again, cut down on size enough that the stretch is no longer a big problem with the capsule. So that's kind of the basics of trying to manage with sedation itself. So ethically, the issue becomes emotional distress, which we'll talk about a little bit when we get into MAID. But different types of sedation, goal of deep sedation is pure unconsciousness with the patient not planned to wake up again. For proportional sedation, doing enough to make that person comfortable, maybe somewhat sedated, but not completely to unconsciousness. And then just medications are too high, but you can drop the dose for someone just doing typical medications. And then brief sedation, which gives the patient a break from whatever symptom they're having, and that can sometimes make them better enough that they don't have to do deep sedation. So medical aid in dying is legal in some parts of this country. This is an excellent slide that kind of shows what leads to the desire for hastened death. Physical burden, as you can see, leads to depression. Depression and hopelessness lead to desire for hastened death. And there are other issues that come into play. The physical burden is one of the largest ones that leads to depression and hopelessness, and then leads to the desire for hastened death. The reasons that people ask for that have a desire for hastened death, these are the reasons that come into play. They're dependent. So they don't want to be dependent. They've lost their autonomy. They can't enjoy things anymore, which could be a sign of depression. The loss of ability to enjoy your normal activities is a classic symptom of depression. Hopelessness. What is the point? I'm not going to get any better. I don't see any reason in continuing to do this. Dyspnea, again, being short of breath when their oxygen doesn't work. They're not going to go on a ventilator, and you've got to help them in some manner or fashion. Other physical symptoms, profound fatigue, cancer-related fatigue in particular, is quite severe, and it's true for anyone who's approaching end of life, their energy levels go down severely, being a burden to others, meaningless. My life has no meaning anymore. There's no value of my life. Or you're lonely, maybe you don't have family support. And so it's like, just get this over with. Pain is one of the reasons for thinking about MAID. And fear of death going the normal possibilities. So gradual progression to death. Let's just get it over with. And other symptoms which are not outlined. So in MAID, you're giving a medication specifically for life termination. And it's prescribed, the patient has to be able to take it independently. And there's an article looking at things we need to change, and they want to change this and to let someone else give the medication to them, particularly the ALS population, who may not be able, because of their paralysis or their problems with weakness in their extremities, may not be able to take it on their own. So they're not eligible to do it, but they might want to have a desire for hastened death, and they're sort of excluded because they may not be able to take it independently. Some people have raised that as being part of a problem with accommodation to the handicapped that one is supposed to be able to do. That in this situation, we're not accommodating the handicapped by making it be done independently. Most common medication is secobarbital, typically around 9 grams, so a very significantly high dose. And the most common indication is cancer. These patients have typically had an increasing symptom severity over a year. And those who choose MAID typically have higher anxiety scores and higher anorexia scores. Not so much pain is not the moving factor here for patient choices to do MAID. It's legal by law in 10 states in the country. It's legal by court ruling in California and Montana. Vermont allows it now without residency requirements that are required in all other states, and access requires a residency status. Vermont changed that within the last year, but the person that's coming to Vermont has to get a Vermont physician to determine that they qualify and to provide the medication. So they can't do it from outside physicians. They have to get a Vermont physician in order to be able to do it. Typically, I see little things coming through the news that a couple went to Vermont and did MAID together for reasons that may not have been as clear cut. But Vermont does allow it now from out of state. The patient reasons for MAID are basically control, loss of autonomy, less ability to participate, which again sort of raises this possibility that we're dealing with a depression situation, and a loss of dignity. So you think about the woman who has no daughters, whose son is going to be doing toileting for her. And that is sometimes quite distressing for the woman who does not want her son involved in her perinatal. But that may be all that not perinatal. Anyway, it's not necessarily something that we can fix, but it is something that distresses the patient significantly. Family reasons were different. So loss of control and bodily functions and autonomy were high, but the physical suffering, which included pain, was felt to be much more significant for the family than it was for the patient. And then the inability to participate, concern for burden. I always try to reframe burden when I'm talking with a patient who is concerned about that, because their family needs to be able to help them. It's therapeutic for the family, for their bereavement, to have been able to help. So I always try to reframe this comment to be, it's a gift to your family to allow them to help. And the family members are always thrilled that we've raised that as something that would be helpful. The other reasons are to control the circumstances of death. So control is a key factor in making decisions to do MAID. And then a prolonged death, they don't want to linger, which they probably would not to begin with, but that's the fear. And despite having advanced directives, They fear an ongoing coma or a respiratory status, a respirator, which they don't want. And those would not happen because of the advanced directives, but they fear that anyway. An important factor. So when MAID first became considered, it was, oh, these people will be poor, and so we're just going to do it because they don't have money, they're not educated, they don't have health insurance, so the cost of their care is out of control, and they're not getting good care at end of life. What we've discovered is those are unimportant factors. Although the vast majority, over 80+% of the patients who choose MAID are college educated. So the lack of education may be more of an issue than we realize because the vast majority of patients are highly educated. The response, the American Academy of Hospice and Palliative Medicine put out a statement looking for how to address this when it came up from a patient. And the first reason, one of the things to be done is to clarify what's the cause of the intractable suffering. Why do they have a desire for hastened death? A study not quoted here looked at AIDS patients who came into a setting where they were looking at whether they were going to die. They wanted to die. Certain percentage of them were depressed, and when they treated the depression, the desire for hastened death went away. So I think that's incredibly important that we take care of the depression, we deal with their emotional, spiritual issues as much as possible, and then they may change their desire for hastened death. Physical symptoms, of course, are part of the problem. With ketamine now being FDA approved for the treatment of refractory depression, it may have a real role to play in this patient population because it's so quick in resolving the depression symptoms. And then they may be able to tolerate their physical symptoms better because they're not so depressed. Their pain may not be as difficult to manage as it is when they're depressed and they have kind of a total pain situation rather than just a physical pain. Another way would be to respond. How would you respond to this? Again, exploring emotional factors, the untreated or undertreated depression, hopelessness, worthlessness, guilt that people may have, fear, and then other mental illnesses. So can we intervene in these things so a patient would not want to have MAID instead? And a certain percentage of patients who get the medication for MAID, about 30+%, never use it. They just want to know it's there. So it's just reassuring to know they could get away from it if they wanted to, but they never do. So we want to explore these factors to see if they can be treated, and therefore they would no longer want me. So is this a failure of palliative care? I would say possibly, because the data suggests that many patients are not getting adequate control of their pain or other symptoms. We should be better now than we've been in the past when some of these first studies came out. We know more about using continuous infusions. We're more comfortable with opioids, with the palliative medicine patient population. We don't worry about it as much. When the CDC came out with all their guidelines in the past ones, that 80 milligrams of morphine was as high, morphine equivalence was as high as you should go. ASCO, American Society of Clinical Oncology, the American Hematology Association, and sickle cell people went to the CDC and said, you are compromising care of my patients because we sometimes need doses higher than that. And the CDC said, oh, we didn't mean you. Well, they didn't say that. So we are now getting better at controlling pain to some degree, but obviously not enough. So I think we still need to be training ourselves. We need to get more comfortable with using IV pain medications, become more knowledgeable about adjuvants such as methadone or ketamine, or occasionally lidocaine infusion has been used. So we need to be aware of the adjuvants that can be done. So the concern is that the interventions less than sedation have not been adequately used. Unfortunately, palliative care, palliative medicine is not necessarily available in all situations, particularly in rural situations that they may not be available. They're trying to get telehealth to remain available in rural situations where there's no palliative medicine physician anywhere nearby. But it's the field that needs more physicians as it is. So they're not enough to cover all bases. So if they're not available, then there again, you may not be getting as good a control of pain as you would want or other symptoms. And as I mentioned, depression not adequately treated, we should be doing better with that as well. So a palliative medicine physician should be able to manage the vast majority of symptoms that a patient deals with. We pride ourselves in being biopsychosocial spiritual. Now we have chaplains that do spirituality. We have patients that do counselors that do the counseling for the psychological stuff, but we're supposed to identify it all and then get the right people involved. So pain management in certain circumstances can be quite helpful. So that's kind of why I think there is potentially a failure in this population of patients. I think there may well be in the MAID population, although since control is the biggest issue, that's something we really don't have any control over, their feeling of control. But I think the sedation, we ought to know how to do it, but we ought to also know when it's not appropriate. And we've not adequately controlled that patient's pain, but we've not pushed the doses, we've got hyperalgesia and we don't realize it, then we should be able to do better so that our patients are not necessarily having to go into sedation for pain control. Unfortunately, some of the times we've seen, as some of the articles mentioned, that it really isn't getting better. So the pain control is not improving, and that's unacceptable as well. So if palliative medicine is controlling pain, then it should get better. If it doesn't get better, then we need to figure out why not, and then try to come up with a method that would improve that pain. So it would not be the reason that this person wants to be, that we think this person needs to be sedated. Families of patients don't want to be sedated. They want to be able to communicate at end of life. So sedation is a last resort. And if we could come up with something not so overwhelming, then that would be good for our families and for our patients. So in summary, symptom distress in the last 6 months of life, it may persist despite the involvement of palliative care. And I think that's a sad commentary. Sedation is an option for refractory symptoms in the proper situations. So I struggle with doing it with emotional distress. I think particularly if one could treat depression or other symptoms of emotional distress, I think I would have a hard time having someone take their life because they're distressed with emotional issues. There have even been a few patients where anorexia has been the cause of a person choosing to do MAID, which again, I would have a really hard time with that. And again, pain is often inadequately controlled, but it's not necessarily as important as death nears, the dyspnea, the delirium, which may happen, happens quite commonly at end of life. And we have to be sure we're not using opioids for sedation, because there again, you may get into hyperalgesia, or you may create some symptoms of delirium because you've gone higher than that person really should have had. So it's not meant to be a drug used for sedation. If we're sedating someone, then we use one of the other medications that were mentioned. So in summary, that's pretty much what I wanted to talk about.